Ankle injuries. How many of you have really suffered from some kind of an ankle sprain? And today we'll be actually discussing exactly these topics, that is the lateral ankle sprain, which is most common, and it is actually the most commonly acute injuries which occurs in usually the runners, gymnasts, as well as normal people as well who are not exercising. Actually, most commonly it is due to the uneven surfaces and inversion injury of the foot. If you see, this is a normal left foot. If you can see it from the back, these are the lateral constraints and these are the medial constraints. If there is sudden inversion of the foot, that is internal rotation, which is also called as supination of the foot, then the increased stress would be placed on the lateral ligaments. But if it's more than what they can bear, this would eventually lead to either tear, partial or complete of the lateral ligaments, leading to these kind of ankle sprains. Similarly, if there's too much external rotation or pronation which occurs at the foot, this will eventually put a lot of load over the medial aspect of medial ligaments, leading to partial or complete tear or even the sprains of the medial ligaments. Now, lateral ankle sprain is one of the most common injuries usually we see in outpatient departments in foot and ankle clinics. Why? Because this is the most commonly occurring injury, as well as leading due to uneven surfaces. There may be a sudden inversion of the foot of the injury and leading to these kind of ligaments. The most commonly ligaments which get sprained are actually the anterior talofibular and calcaneofibular ligaments. Why these actually occur commonly as well? One of the reasons is anterior talofibular ligament is a very weak ligament, and even a small amount of stress can actually lead to either complete or partial rupture of the anterior talofibular. Similarly, if the foot was in inversion and plantar flexion and excessive stress was placed on the lateral side, this will lead to rupture of anterior talofibular. Similarly, if the foot was in dorsiflexion with leading to inversion and stress was applied on the lateral ligaments, this usually results in rupture of the calcaneofibular ligament. As you see, the talofibular means it's arising from the talus attaching onto the fibula, and ruptures in inversion and plantar flexion. Calcaneofibular arises from the calcaneum attaches on the fibula, ruptures in dorsiflexion and inversion injuries. Now, sprained ankle could present with multiple clinical features. When you usually get an X-ray may seem to be absolutely normal. Why? Because these ligaments are actually, when sprained, even if there may be swelling and pain and tenderness, but usually they may not be associated with any bony injuries. And sometimes you have to just do some kind of stress test, especially in this situation. If you see this is a plantar flexion view of the foot. And if you see the lateral view, there's ankle mortise looks absolutely normal. Subtalar joints, tibiotalar joints are all looking very much normal. With maybe there's no osteochondral injury as well. Sometimes there is, but most of the time the X-rays are absolutely normal. Now coming to the grades of the ankle sprain. Now, ankle sprain, when they present, usually they present with patient comes to you with history of pain, mainly on the lateral side, the inability to bear weight, or when there is patient is able to bear weight, there is associated with mild, moderate, and severe pain. And when sometimes what happens is there's always a feeling of giving way. There's instability on the lateral side. So patient comes to you, say that when I'm walking, there is always that I feel like it's gonna give way and my foot is gonna turn inwards. So this is a normal joint. Anterior talofibular and calcaneofibular ligaments are intact. This can lead to a grade 1 sort of a sprain. Now, grade 1 sprain, the ligaments are not torn. They are absolutely normal, but there is, due to stress, there is mild swelling, mild amount of ecchymosis over the lateral aspect and lateral malleolus, as well as there is maybe associated with either mild or no pain at all on the weight bearing. And usually when there is grade 1 tear that resolves spontaneously, patient usually never really bothers to come to the clinic. Patients usually when they come to the clinic, it's always either grade 2 or 3 tear. And why? Because in this grade 2, there is partial tear of these ligaments, which there is mild to moderate swelling, almost moderate ecchymosis, and you can see something is wrong. A patient feels that there is definitely something wrong with my ankle, and there is associated with mild to moderate pain on the weight bearing as well. and that is why they usually come to the clinic, because there is history of swelling, ecchymosis, mild to moderate pain, and inability to walk properly. Now, grade 3 tear means there is a complete rupture of the ligaments, massive swelling, lot of ecchymosis which can be appreciated over the lateral malleolus. This ecchymosis may be extending onto the anterior dorsal foot, extending back towards the calcaneum as well, with inability to walk as well as severe pain on weight bearing. When the patient tries to weight bear, this results in severe pain, and there is definite disability and limiting factors which is actually creating a problem. Now coming to the ankle ligamentous injuries, as I know you know that there is two mainly ligaments which are actually attaching it. One is the talofibular, which is attaching talus with the fibula. There are two further subdivisions of talofibular ligaments, that is the anterior talofibular and posterior talofibular. Posterior talofibular is quite a strong ligament, it usually rarely gets ruptured, but anterior talofibular is a weak ligament, and usually the most common injury is always with the anterior talofibular ligament, which is due to sudden inversion and plantar function of the foot, the ones where with a lot of stress on the lateral side. The other component of the lateral collateral ligaments is the calcaneofibular ligament. Usually it's, as compared to anterior talofibular, it gets ruptured less frequently, but it can get ruptured especially when sudden dorsiflexion of the inverted foot occurs, leading to a lot of stress on the lateral side, and they can lead to either partial or complete tear of the both ligaments as well. Ankle ligaments x-rays, sometimes if you see, this is a talar tilt, but this is usually common when we are doing the stress views. Normally, if on a weight bearing x-ray, talar tilt may not be visible, but stress views can be initiated. Why? Because we want to know what is the situation of these ligaments. There may be partial rupture. In partial rupture, there is not a lot of talar tilt. There is a complete rupture can result in talar tilt, but these are when the stress views are done, which actually show the insufficiency of the ligaments. Other is anterior and posterior instability. Anterior instability is actually checked with plantar flexion. You are checking the actually anterior talofibular ligament, and this results in lot of opening of the talus as compared to in the tibio-talar joint. And when you're getting a lateral view, you can appreciate the talus actually moving forward with anterior tilt in the plantar flexion. And when we are applying the anterior translation of the talus in dorsiflexion, if the calcaneofibular ligament is injured, actually the talus will move forward in dorsiflexion. So this is actually testing anterior talofibular as well as calcaneofibular ligaments. Coming to the functional anatomy, if you see this, there are syndesmotic ligaments which are actually forming the syndesmosis between the tibia and fibula, and then there are extra articular ligaments which are actually not forming the syndesmosis but applying some form of stability to the ankle joint. These include the posterior tibiofibular and anterior tibiofibular ligaments. These are actually part of the syndesmosis, which is anterior. Then there is anterior talofibular and posterior talofibular, which are not part of syndesmosis. They're actually lying outside the capsule. Then there is calcaneofibular ligaments. Most commonly, the injured is anterior talofibular, and then less frequently is calcaneofibular. Usually, posterior talofibular is a strong ligament. It is not injured in low ankle sprains. Anterior inferior and posterior inferior tibiofibular ligaments are actually injured in the syndesmotic injuries or in high ankle sprains. Now coming to the pathology. The cause is most commonly is unbalanced loading. Most commonly when the lateral ligaments are injured is always the inversion injuries, which can lead to ATFL, that is anterior talofibular and calcaneofibular ligament injury. There may be calcaneal ligaments may also be sprained as well. That's need to be ruled out. Fibers may be torn, or avulsion of malleolus fractures may be seen on the X-ray as well. Most of the time the X-rays are normal, but there may be avulsion injuries of the lateral or medial malleolus. Then there could be associated peroneal retinacular tears as well. When superior and inferior retinaculum tears off, this may lead to eventually the peroneal tendon subluxation as well as dislocation. And usually isolated medial ligament tear is not common. The most commonly it is associated with other injuries as well, like tears of the retinaculum, like subluxation or dislocation of peroneal tendons. It may be associated with osteochondral fragments as well. That is the small fragments of bone which may be torn off from the surface when the tendons or ligaments actually contract drastically. This may be leading to osteochondral fragments which may be visible on the X-ray. Now coming to the acute injury of the lateral ligaments, what were the clinical features? As I told you, the most commonly it's always an inversion twisting type injury. This leads to pain and swelling. Patient usually comes up that he or she had some kind of a trauma. After that, there is definitely swelling on the lateral aspect of the foot, and there is pain, and patient is unable to walk properly, and there is pain on the weight bearing as well. And sometimes there may be a bruising or ecchymosis which may be visible on the lateral side, and that is actually the criteria. We divide them into the different grades. That is either it's grade 1, grade 2 or grade 3, and then you initiate the treatment regarding the acute injury of the lateral ankle sprains. Now coming to further clinical features, first there is inversion injury. This may lead to either the rupture of the calcaneofibular or anterior talofibular ligaments. Maximum tenderness are on the lateral malleolus. There is pain on the passive inversion of the foot when the patient doctor is testing doing a stress test and inverting the foot. There is actually maximum tenderness over the anterior lateral aspect of the ankle. And you can test the mobility testing is done on anesthesia because these are mostly highly painful, especially when we are doing the anterior drawer test or for anterior talofibular calcaneofibular ligament. You need to first numb the patient so he or she does not feel the pain during the anterior translation, and then we can get the x-rays and plantar flexion and dorsiflexion to know whether either it's ATLF or it's calcaneofibular ligament which is damaged. Imaging, it may be very much normal, but it may sometimes show osteochondral fracture or it may not show anything at all. Usually there is pain around the malleolus, in this case mostly around the lateral malleolus, inability to walk, and usually patient may not be able to take even 4 steps in an emergency because the pain, if in case of a grade 3 injury, the pain is severe enough that patient is unable to even weight bear at all. Bony tenderness at the malleolus is the most common sign, especially associated with ecchymosis. If we are going for the imagery, usually X-rays, if it's a simple low ankle sprain, it's normal, but it can be associated with the fracture of the lateral malleolus. Deltoid ligament may be avulsed as well, which may be showing increased medial clear space. There may be a mortise view which will show this kind of a picture. You can appreciate lateral malleolus is fractured, increased clear space of the medial malleolus. There may be some other fractures as well. Or if you see it on the lateral view, you can appreciate there is definitely subtalar joint is also disrupted, as well as the tibia-talar joint is disrupted as well. But although there is no definite fracture of talus or calcaneum which can be visible. Now, localized soft tissue, especially in the case of children, if the X-rays are normal, then sometimes it does warrants that you may need to go for some other modality of choice as well. Sometimes they present with avulsion fractures. You see this is such a small fragment which is probably something has happened. It could be either it calcaneofibular ligament or it could be talofibular ligament which may have avulsed from its origin. Sometimes you need more than X-rays and you have to go for CT scan or MRI. Now, if you see this MRI, this definitely you can appreciate that this is the talofibular ligament which is actually torn right over here, and calcaneofibular ligaments appears to be torn as well, and you can appreciate there's a lot of edema or just below the lateral malleolus. Sometimes CT scan would show the osteochondral defects which may be associated with these ligamentous injuries. Now, what is the treatment? Once we have diagnosed that there is an acute injury to the lateral ligaments, then what is the treatment? The treatment could be initially non-operative. This is called as RICE approach because RICE stands as a mnemonic for rest. That is, you ask the patient to keep non-weight bearing for at least 2 to 3 weeks. Then there is a compression in form of crib bandage, or it could be in form of some other materials as well. Then ice packing to reduce the swelling and to reduce the edema as well as the pain which this patient is experiencing, as well as elevation. Now, elevation would not only reduce edema, would also reduce so it would result in a better circulation towards the ankle joint. Similarly, ice, compression, and elevation, all that, if it is combined with analgesics as well as other modalities, they are very effective in case of acute injury to the lateral ligaments. Now this mnemonic actually has been modified to PRICE. Why PRICE? Because P stands for protected weight bearing. Once you have asked the patient to elevate it, you're giving painkillers, you're giving rest as well as ice packing and everything, you need to protect it as well. Once after 2 weeks, when the patient starts partial weight bearing, you need to keep this ankle ligaments protected for at least 6 weeks. So that is why it is called as PRICE, because protected weight bearing and topical analgesics are painkillers along with rest, ice, as well as compression bandaging and elevation. These are the treatment mobility, treatment of choice for acute injury to the lateral ligaments. If there is usually acute injury can be most commonly dealt with conservative measures, but sometimes the injury is severe enough and there is complete tears which can eventually lead to lateral ankle instability. So you may need to do the operative repair of these ligaments, that is repair of anterior talofibular or calcaneofibular ligaments. Now mostly nowadays these are done by arthroscopic repair, but it can done by open procedures as well as minimal invasive procedures, for example leading to ligament substitutions, but mostly it is repair is done by arthroscopic nowadays. Now if these repair are even despite the acute and conservative measurements, sometimes this can lead to recurrent lateral instability, that these ligaments over their period actually become degenerative and arthritic and eventually do not provide the stability on the lateral side. So if that has happened, this eventually leads to recurrent lateral instability. This may lead to the patient may not have any kind of a trauma, but despite didn't walk, that will be associated with a sprained ankle. There could be a recurrent history of multiple episodes of trauma, that patient have multiply twisted inversion injuries and has suffered from these kind of sprains on multiple occasions. There could be a feeling of instability on walking, that patient comes and tells you that I had that injury that month, 6 months, 1 year back, and after that whenever I walk there's always history that my ankle is going to give way. And then if there is minimal tenderness or there is no pain, then you can go for stress test views, especially if you see this is a classical talar tilt mortise view. That is, the inversion of the foot is done by the examiner, and then x-ray the mortise view is taken in inverted foot, and you can appreciate how much talar tilt is actually present over here. If the ligaments would have been intact, talar tilt would not have been possible. So then there are other tests as well to check for anterior drawer as well as in this case, if we are checking for anterior talofibular, we can do the anterior drawer in plantar flexion, and if in this case it's doing in dorsiflexion, means it's checking for calcaneofibular ligament. And if you can see the x-rays, the foot is in plantar flexion, how much translation of the talus actually has occurred in the tibio-talar joint. This is an indication that there is actually complete rupture of anterior talofibular ligament. Now talar test, as I've already told you, that the foot is inverted, maximum stress is applied on the test, and then we can get a mortise view. Once we get a mortise view, we can appreciate how much talar is actually there. Usually there is very little movement of the talus, but if there is a lot of movement and increased angulation, that means talar test is positive and there is definitely damage to the lateral ankle ligaments. Now, how to treat this if there is a recurrent instability? Most of the time the tendons most of the time the ligaments have become degenerated and they are gone to a stage which is beyond repair. You cannot have simply end-to-end repair as well. So the one option is actually to go for dynamic ankle stabilizers, use of different orthotic devices, or use of modifying footwear, in which so that it actually provides more stability on the lateral side of the foot. Or we can go for ankle exercises. Why? Because strengthening the muscles around the ankle, because there is actually extensors, then there are plantar flexors which are actually going through the ankle. If they are strengthened, the peroneal tendons are strengthened, then they actually apply a lot of stability to the ankle mortise. The next option is use of light ankle brace, especially which is actually extrapolated on the lateral side, so that it provides more stability on the lateral side. If all these fail, that or the orthotics or footwear or even the exercises are not sufficient and the patient still complains of lateral or recurrent lateral instability, then we may have to go for operative treatment. Now, operative treatment usually does not involve repair, because the ligaments are beyond the stage which they can be repaired. Mostly they involve lateral ligament reconstruction or arthroscopic ankle reconstruction. Now, nowadays there's no more trend towards doing arthroscopic reconstruction, but open and arthroscopic, both reconstruction of the tendons can be done. As you can appreciate over here, this is an arthroscope in which basically inserted from the medial side, the camera has been inserted, and trocars are actually inserted to the lateral side, from which we need to fix the ligaments. Now, what is the operative treatment? There are multiple treatments options. One is actually called as Boström Karlsson operation, in which actually what they do is they do not repair the tendon, but what they do is they attach the inferior retinaculum towards the fibula, and as well as attaching this would result in stability over the lateral side, because the talofibular and calcaneofibular ligaments have degenerated enough beyond the stage of repair. Therefore, an inferior retinaculum can function as a ligaments. Other is actually Chrisman operation. It's called as Chrisman Snook operation, or it's called also Watson Jones operation, Evans surgery as well. There are different modifications of this procedure, but almost all involve one common thing, that is involvement the tendon of peroneus brevis. Peroneus brevis and longus are actually coming right over here, just below in the retrocalcaneal groove. As they are coming through the retrofibular groove, as they descend down, this one slip of the peroneal brevis can be rerouted through the fibula and attached through the pass again through the inferior fibular retinaculum attached on this surface. Now, this procedure is actually providing the lateral stability to the fibula and not allowing the fibula to sway or to translate during the stress of the lateral side of the. So it actually using the tendon to provide a dynamic support and stability to the lateral side of the ankle. Now moving on to the deltoid ligament tears. As you know, the deltoid ligament is present on the medial side of the ankle, and it's actually the most important restraints to the valgus movement of the talus. There are two parts, the superficial and the deep part. The superficial part usually crosses both the ankle joint as well as subtalar joint, while deep part, which is the most important, actually crosses only the ankle joint. Isolated injury of the deltoid ligaments is highly rare. Usually it's associated with either the fracture of the distal end of the fibula or the syndesmotic injury, or this may be associated with the tearing of the distal tibiofibular ligaments. Usually that is the syndesmosis is usually involved as well. That is anterior inferior tibiofibular and the posterior inferior tibial fibrils may be torn along with the deltoid ligament. Although it can happen with an isolated injury, but usually it's highly rare. Now, there is called as Masonov fracture, which is associated with the deltoid ligament tear. If you see on the lateral view, along with the deltoid ligament tear, you can appreciate there is actually posterior tibial pylon fracture, or there is actually fracture of the posterior malleolus, which is extending into the tibia, which is called as Masonov fracture. This is very common associated with the deltoid ligament injury. Now coming to the treatment, usually what happens is, as I told you, it's not an isolated injury. we have to, when we are looking at the x-rays, we have to look at the medial clear space. If it's more than 4 mm displaced, we may have to go for stress test, and in stress test it actually gets displaced more. This means definitely there is the injury to the deep part of the deltoid ligament. But what we need to rule out is what are the other associated syndesmotic injury or not. And if you can appreciate this, there was syndesmosis injury along with the medial ligamentous injury as well, which was actually syndesmotic screw has been utilized to used to actually fix the syndesmosis along with the plate which is being used to fix the fractured fibula. There sometimes syndesmotic injury, there will not be complete tear of the deltoid ligament, or there may only be a tear involving the superficial part, for which we can go for below knee cast for at least 4 to 6 weeks, or even using a support boot or cam boot for at least 6 weeks with protected bed bearing. Then comes the dislocation of the peroneal tendons. Although it's again very rare, but what happens is sometimes in case of inversion injury, this may be associated with tear of the superior or inferior retinaculum as well. And as you know, when the peroneal tendons which are descending down from peroneus brevis and peroneus longus, they descend down into the retrofibular groove, where the peroneus brevis is actually lying superior and peroneus longus is lying slightly inferior. Then they enter right into the inferior retinaculum, where they are actually peroneus brevis is still superficial and peroneus longus is descending downward and more towards more plantar as compared to the peroneus brevis. And as peroneus longus has to wind round across the foot and attach it on the middle malleolus on side of the middle side of the foot, while the peroneus brevis mainly attaches on the cupide over here. What is important is that sometimes the peroneal retinaculum may get disrupted, and there's either subluxation or a complete peroneal dislocation. When this happens, this leads to calcaneofibular impingement, and the patient is complaining of pain on the lateral side. When you get an x-ray, you get this kind of an x-ray that actually the fibula is impinging onto the calcaneum on the lateral aspect. We may need to get an MRI or even the CT as well, just to view out if they're not associated with some kind of a fractures. And on MRI, you may see there is actually complete tear of the retinaculum, may be associated with partial or complete tear of the tendons as well, but you need to confirm it by use of MRI of the ankle. So what is the treatment? The treatment, if there is simply subluxation, dislocation without any tendon tear, we can go for simply below knee cast for 6 weeks, or ankle immobilization for 6 weeks in form of and keeping the patient in non-weight bearing or protected weight bearing. Other option is that if it's associated with peroneal tendons and the retinaculum is disrupted enough that it cannot be repaired, then probably will require some surgical stabilization to keep the peroneal tendons from dislocating again and again. And usually that is the reconstruction is done by anterior part of retinaculum is either primarily repaired if it is repairable, or it can be reconstructed as well. But if it's a chronic injury and there is actually associated with recurrent dislocation of peroneal tendons, then we may require to deepen the groove between the peroneal tendons so that the peroneal tendons can pass along with the reconstruction of the superior and inferior retinaculum as well. Now coming to the tears of the inferior tibiofibular ligaments. As you know that there are actually high ankle sprains and low ankle sprains. High ankle sprains involves the syndesmosis, and there are actually 4 ligaments which are mainly involving the syndesmosis. Some actually make it 5. Mainly they are the anterior inferior tibiofibular ligaments and posterior inferior tibiofibular ligaments. There is interosseous membrane, interosseous ligament, as well as transverse tibiofibular ligament. These actually form the syndesmosis. Tibiofibular are anterior inferior tibiofibular and posterior inferior tibiofibular ligaments leads to high ankle sprain and syndesmotic injury, which can be appreciated in this diagram as well. Now there are tears. There could be partial tear or there could be complete tears. If there is tears of the inferior tibiofibular ligament and usually associated with complete diastasis, that is, how do you check the diastasis or how do you check whether there's syndesmotic injury as well? Then when you're viewing an AP view of the ankle joint, and you see there is usually an overlap of more than 6 mm of the tibia over the fibula. But if this overlap is less than 6 mm, or there is complete diastasis, that the tibia and fibula appear as two separate bones, then this means there is definitely syndesmotic rupture. This usually means that there's tearing of both the anterior and posterior inferior tibiofibular ligaments, which usually follows a severe abduction strain, could be in form of pronation abduction, and most commonly. Or then there could be a partial diastasis, that is, there is some form of rupture is there, although it's less than 6 mm, but it is not complete disruption. This means either anterior or posterior is usually ruptured, but most commonly anterior inferior tibiofibular ruptures, leading to some form due to external rotation. This could be supination external rotation or pronation external rotation injury, which may lead to anterior inferior tibiofibular injury. It usually occurs in isolation, but it's very rare which is occurring in isolation, and associated with fractures of the malleolus, that is the as well as the rupture of the collateral ligaments as well. Now, what are the clinical features? Usually the clinical features include there is always history of some kind of a twisting injury at the ankle joint, and depending upon what type of force was acting, whether it was supination external rotation or pronation external rotation force, which usually leads to syndesmotic disruption, this may be leading to the pain at the ankle joint, inability to bear weight, as well as massive swelling over the ankle joint, and ankle tenderness. Now, depending upon what type of injury it is, if they may be associated with medial malleolus tenderness, there's definitely lateral malleolus tenderness, there's joint instability along with inability to bear weight as well. Now, this is called a squeeze test. This is actually squeeze test is there for the check the integrity of syndesmosis. As you know, the syndesmosis is present right over here, and it's actually involving the interosseous membrane ligament, transverse tibiofibular ligament, as well as anterior and posterior inferior tibiofibular ligaments as well. When the examiner squeezes both the tibia and fibula together, as interosseous membrane is disrupted, this leads to pain over the during the squeezing of both the bones, and this is actually which means that the most likely there is also associated syndesmotic injury, and there may be a disruption in the interosseous membrane as well. Now, what are the imaging? If you see, this is an AP view, and you can appreciate there is some degree of overlap of the tibia over the fibula. Now, this overlap should be at least 6 mm. If this overlap is not there and tibia is separate and fibula separate, this means this is definitely syndesmotic injury. If you see, this is the group which is actually visible. If this has actually separated more than 5 mm, and this is also indicative of there is some either partial or complete tear of the syndesmosis. And when you're looking at this AP view, you need to also look at the medial clear space as well. If this medial clear space is more than 4 mm, this means not only the syndesmosis, there is also deltoid ligament injury as well. Then you may have to go for CT or MRI, and MRI will usually show the ligamentous injuries which may be leading to syndesmosis involving anterior, inferior, as well as posterior inferior tibiofibular ligaments. Then what is the treatment for partial tears? Partial tear starts with strapping of the ankle firmly in form of ankle brace, and then they may have to give analgesics exercises as well if there is partial tear. And protected weight bearing is at least carried out for 6 to 8 weeks so that the patient can recover properly. But if it is a complete tear, it usually involves the repair of the syndesmosis, or if this is associated with malleolar fractures, then you need to repair the syndesmosis as well. If you can appreciate in this X-ray, the medial malleolus was also fractured, in which the 2 screws are going into the medial malleolus, and 1 screw is actually going through the syndesmosis to repair with internal fixation with the screws. Now, this is another view in which there was actually either supination external or pronation external rotation injury, in which you can appreciate the ORA has been done to the fibula, as well as syndesmotic screw is being passed through the from the fibula into the tibia. Now, usually the way to pass a syndesmotic screw is actually 30 to 40 degree of anterior angulation and from the fibula into the tibia. There's still debate whether one screw or two screws should be passed. Usually, there's no clear-cut evidence whether one or two should be passed, and then again whether you need to involve three cortices as been involved over here. The two cortices of the fibula and one of the tibia, or four cortices, that is involving both the two cortices of the tibia as well as the fibula. Now, if there is continuing with the treatment, usually the complete tears needs to be reconstructed, and reconstruction could be in form of transverse screw fixation through the syndesmosis or open clearance of the syndesmosis, which needs to be done as well. Now, in this lecture, we have mainly covered through the ankle ligamentous injuries, which could be low ankle sprains in form of anterior talofibular ligament or calcaneofibular ligaments. Usually, conservative measurement is enough, and if rarely it requires a open surgical approach. But this may lead to recurrent lateral instability, which may require either the using of retinaculum to reconstruct it or reconstruction by using of peroneus brevis in Chrisman snook operation. Then we have covered the high ankle sprains as well, which may be associated with malleolus fracture leading to syndesmotic injuries. What is important is that when there is associated syndesmotic injury, you need to reconstruct it with either ORI and plating with syndesmotic screws, which could be either one or could be two, and may involve the 3 or 4 cortices as well. Thank you very much. Keep watching sqadia.com.